go ahead and jump right in and get started. Here's what I want to cover in the next 45, 50 minutes before we leave time for questions and answers at the end. We're going to be talking about MIPS, and we're going to look at this at what's happening in 2017 and what's happening in 2018. All right, in 2017, one of the questions that we want to make sure that everybody's able to answer at the end is, what's a transition year? What is that? What does that mean? And what do I need to do for my practice in a transition year? The next question we want to be able to answer that I get a lot is, we haven't started yet. Can I still avoid the penalty? The answer is yes. We're going to talk through this. Some of you may have already started. Some of you may be in your 90-day period now. Some of you may still have that ahead of you. But we're going to walk through what that looks like in 2017 and what you need to do in order to be successful. Then we're going to spend some time looking at 2018. There are some changes that are coming next year. Some of the low volume thresholds are changing for next year. There are some bonus points that are available for next year. Some of the measures will be largely intact. The performance threshold will be different next year, but we're going to walk through all of those so that you understand what 2018 will look like compared to this year. Some people are thinking it's kind of another transition year. There's still a pretty low bar. There's still a lot of flexibility of what you can do if you want to avoid a negative adjustment. So we're going to walk through that so that everybody has a good feel of what 2018 will look like. And then I do want to spend some time thinking strategically about the decisions that you make for how your practice will report on MIPS. Right? There's a lot of decisions to make. From a reporting options standpoint, am I going to report as a group, or am I going to report individually? Right? Which measures are we going to choose? There are a lot of choices here. How do we want to do that? What's our reporting mechanisms going to be? Because I have to choose that for each different MIPS category. And then we'll also walk through the MIPS scoring methodology. Right? Everybody knows you get a score from 0 to 100, but there are a lot of components to go into that. And it's not as straightforward as you might expect to go from your MIPS score to what does that mean from a reimbursement perspective. So we're going to walk all the way through that. Again, the handouts are there if you want to go ahead and download that in order to take notes. If you have questions as we go, feel free to ask Shelly, and we'll try to answer as many of those as we can. All right, so let me start off with some good news. CMS gave us a lot of flexibility with MIPS in 2017, right? Some of you may be familiar with this slide. CMS has had this all over their website. But when we first started, we really thought that it was going to be, you have to submit for a full year starting January 1st, 2017, if you wanted to be able to participate and avoid the -4% negative adjustment. They don't call it a penalty anymore. They call it a negative adjustment, but those are the exact same things, right? So we thought we were going to have to participate for a full year when MACRA, the legislation, first came out of Congress. The good news is they relaxed that standard. They implemented this idea of a transition year that says, you know what, if you just want to submit something, if you just want to submit anything, you can avoid a negative adjustment. You've got flexibility in how you do that, in what you choose to submit, right? And you can do that and avoid the negative adjustment based on the 2017 performance data. If you want to do a little bit more and do it for 90 days, you could do that too. You may get a higher score. You may be able to get a small positive adjustment. So they gave us a lot of flexibility. So it should be very, very easy for everybody on the call today to avoid the negative adjustment, right? Even if you've done nothing so far, you still have time in 2017 to avoid the negative adjustment. I want to make sure that I say that very clearly so that everybody's blood pressure can come down just a little bit. If you think you're behind, that's okay. There's time to catch up. There's still time to avoid the negative adjustment in 2017. Even for those of you who do not have an EHR, you can still avoid the negative adjustment. Right? I know we've got some clients on the call today who don't have an EHR. You can still avoid the negative adjustment too. You've got lots of options as far as how you can do that. Let me show you what those are for 2017. The first one is if you want to submit one quality measure. You submit one quality measure for 2017. This is what was formerly PQRF. You can do one quality measure in 2017 and avoid the negative adjustment. Or, this is not and, this is or you can do one improvement activity. This is another MIPS category, clinical practice improvement activities. If you do just one of those, your group or your individual provider can avoid the negative adjustment in 2017. Or if you want to do the 5 core measures for advancing clinical information, if you want to avoid that's another way. That was what used to be meaningful use, but the 5 base measures are a little bit different in MIPS than they were in meaningful use. We're talking about e-prescribing, patient access, the security risk assessment that's required in HIPAA, and then sending or receiving a transition of care. We're not talking about CPOE. We're not talking about clinical decision support. Again, a very, very low bar compared to what it used to be under meaningful use. So avoiding the negative adjustment in 2017 is something that you can do even if you haven't started, right? You can do that in the 4th quarter, one quality measure, one improvement activity, the 5 core measures for advancing clinical information category, and avoid the negative adjustment in 2017, right? You do have to make a decision, and you want to think strategically about this, both for 2017 and 2018. This is, what am I going to do? How do I want that deal with MIPS? You know, am I going to do the bare minimum, right? And some people really like this approach because it says it's the least amount of change for me. It's the least amount of change for my doctors. We really are tired. We've gone through lots of government regulation over the last 6, 7, 8, 9 years. When you think about what we've been through with e-prescribing and meaningful use and PQRF and ICD-10, there's been a lot of change in our organizations. And some people are ready to just take a break. They said, if I can do that and avoid the negative adjustments, right, I'll be okay. You know, maybe the government will kick the can down the road and make 2018 a transition year 2. And we're going to see 2018 is not going to be as difficult as we originally thought either. So I have a lot of people that are adopting this strategy. But there are just as many people that are taking the opposite approach. It says, you know what? If a lot of people aren't going to really go for this, maybe I should. I can maximize the positive adjustment. If I get a score for exceptional performance greater than 70 for 2017, I'm eligible for up to a 10% bonus, depending on how well we do, right? I know that these adjustments are going to get bigger over time. Yep, it's just a 4% negative adjustment now, but that's going to grow up to a 9%. So I want to use the transition year to practice, to prepare, as we're going to have to roll this out a bit further. And some of these things that are required under MIPS, my practice is doing already. So I'm going to try to maximize my performance under MIPS, right? And then the last piece that I hear some people talk about is, you know, eventually this data is going to be public facing on the Medicare Physicians Compare website. And it may not necessarily be the financial decision for the positive adjustments that's driving our participation, but I know that I'm going to have patients that are looking at that. And I want to make sure that we get out ahead of that compared to what my competitors are doing. So you need to think strategically about what you're going to do for MIPS in 2017, how you're going to participate, and how you lay that groundwork for what you want to do in 2018. All right, I know I'm moving through this fast. We're going to cover a lot of ground today, but don't worry. We're going to leave time for questions at the end, and we're always happy to do follow-up information if there are questions a bit later. All right, so I'm going to try to open up the next poll question for us at this point, and what we're asking here is, what is your practice's strategy for MIPS in 2017? Are you going to participate for the full year? Are you going to do just the 90 days and you've already started? We're going to do 90 days, but we haven't started yet, meaning I'm probably going to do this in the 4th quarter. Are we just going to try to avoid the negative adjustment? Or there may be some of you that are not participating in MIPS. You've looked at the low volume threshold requirements, and you don't have people that you're not required to do that. So we've got, just FYI, we've got about right now 20% of you that are participating for the full year, another 20% that have already started their 90-day period, about 40% who are going to be doing that in the fourth quarter, and then another 20% who are going to try to avoid the negative adjustment. So just an idea of what everybody else is doing. Thought that might be helpful to share with you. So thanks for participating in the poll. It always is nice to have that be a bit more interactive rather than just me talking the whole time. So thanks for participating. So when you think about that, before I jump in and look at each of the individual measure categories and really kind of jump into some of the details of that, I want to zoom out. And I want to think about what is Medicare trying to do? What is the government trying to do with this program? What's the whole point of MIPS? And you look at this, what Medicare is trying to do is bend the Medicare cost curve, right? We have baby boomers that are very quickly aging in to the Medicare population, right? And that trend is going to continue just from a demographic perspective. That's not going to change anytime in the near future. And in order to bend the cost curve, they cannot do that themselves. The payer cannot do that alone. And so the government, the Medicare is trying to engage patients, and Medicare is trying to engage providers to accomplish this triple aim of healthcare. You know, better care at lower cost with a better patient experience, right? Nobody would object to that as a goal, but the devil is in the details as far as how do you actually do that. And so they're trying to push some of that risk, push some of the share some of that risk with both patients and physicians. And we've seen this already, right? As patients have started to experience higher premiums and higher deductibles, right? They are getting more engaged in some of these decisions. They may not be making the best decisions, but they are becoming more engaged. And some of that risk financially is transferring to the patient. And at the same time, we've also seen through the QPP and APMs and MIPS and the government programs and risk-adjusted reimbursement, the payers are shifting some of the risk to the providers as well, right? This is the beginning of the transition from volume-based reimbursement to value-based reimbursement, to moving away from just fee-for-service to paying for quality outcomes and cost effectiveness. And when you think about it in that regard and you start to look at what's happening, what the different MIPS categories are, you can, through that lens, you can start to see what's happening from a big picture perspective, right? So you start to look at what these MIPS categories are, and there are 4 categories in MIPS. And we're going to talk about all 4 of them. I'm going to walk through each of them, but they are cost, quality, improvement activities, and advancing care information. Okay? Advancing care information is just a new word for meaningful use, right? The meaningful use program is over. The advancing care information is now a category under MIPS. You get a lot more flexibility. Some of the things that people didn't like about meaningful use have gone away. There aren't a lot of all or none measurements. If you miss something by just 1%, you still get partial credit for that. You get a lot more flexibility in how you use your EHR. You've got some control back in that, and I think that's really good, but it's still a part of MIPS. The quality measures, you'll see that's the biggest individual category in MIPS in 2017, and will be for 2018 as well. That category, quality is very, very similar to PQRS. If you're familiar with PQRS, the quality measures under MIPS will be very, very familiar to you. The cost category is not going to be part of the measures for 2017. I'll talk more about that in a minute. It's actually not going to be part of 2018 either. That's some new information that just come out. It will not be a part of 2018, but will in 2019. And what you notice there is cost and quality by law are always going to be 60% of your MIPS score. You want to know what Medicare really cares about? It's cost and quality, right? Yes, there are categories for improvement activities. Yes, there are categories for advancing care information, but the two biggies are cost and quality. And that's really what I want you to take from this slide is that's what they care about, that's what they're trying to measure, and that's what the negative and positive adjustments, or 60% of it is going to be based on cost and quality. So you need to make sure that we focus on that. All right, those are the four categories. I'm going to walk through them so that we can look at examples. You can understand what the choices are. You can understand how that works, okay? Now, you may want to look through and make decisions for your practice on which measures you want to choose. And White Plume's actually helped some of our clients make those types of decisions. So if you need help with that, if you've got questions on that, feel free to reach out to us. We'd be happy to try to help you on that as well. All right? So these are the four categories. I mentioned to you there's some slight changes from 2017 to 2018. Let me take a quick look at that for us. Here's what's changed from 2017 to 2018. One of the big changes, and they're trying to make this a more provider-friendly program. One of the changes that has been made, particularly to try to help smaller practices, is the low volume threshold has changed. In 2017, you could not participate in MIPS if you did not see over 100 Medicare patients or didn't have over $30,000 in allowed charges. Say that another way, if you only billed Medicare $29,000 and you saw 200 Medicare patients, you could say, you know what, I don't need to participate in MIPS. That low volume threshold is increasing in 2018. So if you see fewer than 200 unique Medicare patients, you do not participate in MIPS. If you bill Medicare for less than $90,000, you do not participate in MIPS. And you can see that's a significant increase from 2017 to 2018. The low volume threshold also, people are exempt from MIPS if they are the first year that they are billing Medicare. So if you've got new physicians that joined your group that just came out of a residency or fellowship program in July, they will not be participating in the first year. That's true in 2017 and 2018. Another change in the regulation, we originally thought there was going to be a cost measure for 2017, and that got pushed back to 2018. Well, they're taking the ICD-10 strategy on this, and it's been delayed again for the cost measure until 2019. Do not expect we'll see that delayed past 2019, as that would require change to the law. That's not something that Medicare can just change on their own, but that's getting pushed out. They'll still calculate the cost measure, but it will not be part of your MIPS score. All right. The performance threshold changes from 2017 to 2018. The performance threshold is, this is the score that you have to get if you want to avoid the negative adjustment. You've got to get a 3 out of 100 this year if you want to avoid the negative adjustment. If you want to be eligible for the $500 million bonus pool, you've got to score over a 70 this year, right? That's for exceptional performance, right? You will receive that is not, they're not going to necessarily divide up all $500 million of that. It depends on how many people achieve exceptional performance, and that is capped at 10% bonus. So if you only bill Medicare for $100,000, your bonus cannot be any more than $10,000. The performance threshold for 2018 right now it looks like it's going to be 15, so 15 out of 100. If you want to be able to avoid the negative adjustment next year, the exceptional performance threshold is not going up. It's going to stay at 70. This is one thing that may change in the final rule. You may have CMS respond to additional lobbying efforts to bring that back down. So you may end up seeing that performance threshold be a little bit lower, but I do not expect it will be any higher than 15 next year. Maximum negative adjustment this year is 4%. Maximum negative adjustment next year is 5%. The reporting period, one of the changes that they're making for next year is you can still do 90 days for advancing care information. You can still do 90 days for improvement activities. But if you want to do quality measures, you need to do that for a full 12 months. Again, that may be something that they end up pulling back to 90 days when the final rule comes out here. Two other quick points. There are some bonus points that are available next year that would be new. One is a small practice bonus. So that's any group that has less than 15 providers is considered a small practice, and they would get 5 bonus points. So that's 5 out of the 15 that you need to avoid the negative adjustment through just by being a small practice. There are also bonus points available for complex patients. Complex patients are people that are dealing with patients that have high HCC scores. For those of you who are regular webinar attendees, I am sure you know what HCC scores are, but if you don't worry, we're going to get back to that when we start to look at the cost measure in just a few minutes. So those are some of the changes. You can see they're not a lot. I think the high points that I would emphasize are low volume threshold changes, performance threshold changes from 3 to 15, and then some of the bonus point availability. But 2018 is going to look pretty similar to 2017. And so that's why I wanted to talk about this at this point before we look at the individual measures, because the game is going to be very similar. You know, how many points you want to get, how many points you need, that may change a little bit, particularly for those of you who are just looking to avoid the negative adjustment. But I still would expect most practices should easily be able to get to 15 points. Now, if you're thinking ahead and you're planning ahead for those types of decisions. All right, so now that I'm ready, I understand what 2017 looks like, I understand what 2018 looks like, and I'm thinking about what does my practice need to do for those of you who haven't started yet, for those of you who are just trying to avoid the negative adjustment this year. And as you start to think about 2018, you've got some decisions to make. The first decision that you have to make is, are we going to do this as individual providers, or am I going to do this as a group? I do this as individual providers, or I'm going to do this as a group, because I've got to make that decision, and it applies to all of my MIPS categories. I can't choose to do quality as an individual and advancing care information as a group. I've got to do that the same way for all of the MIPS categories. But once I make that decision, it impacts my reporting mechanisms. So one of the big things that you'll notice if you look at this slide is when I do this, I have some options under the group reporting that I don't have under the individual reporting. You'll see there are some things like a registry. I can use that to report for all of my MIPS categories. The cost measure that you don't see on this slide is calculated automatically based on claims data. So I can attest to advancing care information and improvement activities. But I can't do attestation for quality. I actually have to submit the data in order to do that. So you need to think about, do I want to report as an individual or do I want to report as a group? And then what is my reporting mechanism going to be? There are a lot of registries out there, right? There are a lot of registries that you can choose from. If you're reporting as a group, you can use the CMS web interface for all 3 categories. But that's something that you need to think about. How do I want to report? What mechanisms do I want to use for these individual measures? Okay, so let's look at each of these categories. I'm going to walk through them. I'm going to give you examples so that you can understand and think about, okay, if I'm trying to avoid the negative adjustment, which ones are we going to choose? If I haven't started yet, how do I want to do that in the fourth quarter? So we're going to take a look at each of these individual categories. We've got, if you want to see some of the examples that we show, let us know. We can send you an Excel spreadsheet that we've downloaded that has all of that information in it. So advancing care information. Remember, this is the new meaningful use. And so there are two elements. There are some optional elements. There's some required elements for the base score. So if you just want to avoid the negative adjustment, you need to do all 5 of the base score items. That's e-prescribing, patient access to information, right? So can they don't have to, but can they view, download, or transmit the data? Doing the security risk assessment, which is required under HIPAA anyway, and then sending or receiving transition of care. And so one of the things that people talk about when they look at advancing care information, they go, gosh, that is actually a lot easier than what we used to have to do under meaningful use of stage 2. Now, if you wanted to try to go for a bit higher score, there are additional measures that you can choose to report on. You don't have to report on all of them, right? You can choose which ones you want to do, what makes the most sense for your practice, what works well in your EHR, right? I can avoid some of the things that were particularly difficult, right? CPOE being one of them, clinical decision support being another of the kind of the big complaint points that required lots of clicks for the clinical staff. You can see a lot of this is a little bit easier for some of the practices to do. And some of the requirements for the base score, you can actually get points for additional measures as well. All right. So advancing care information is one of the MIPS categories, right? If you remember, that is 25% of the total MIPS score, right? But if you say I don't want to do advancing care information at all, I can avoid that entirely. All right. Let's look at the next one. Let's look at improvement activities. You get a lot more choices when I start to look at improvement activities. This is a totally new category. This is not something that anybody has done before. There are, if you want to fully participate in improvement activities, you need to do either 4 medium priority activities or 2 high priority activities. And there are 93 activities to choose from. They sort them into 8 different domains. So you can see in each domain, there's at least 1 high priority activity and 1 medium priority activity. So you've got a lot that you can choose from. What makes the most sense for your patients? What makes the most sense for your specialty? What makes the most sense for your clinical team? You've got some flexibility here to choose how you want to participate from an improvement activity perspective. So let me give you some examples so you can see what some of these improvement activities are. We've heard some people saying that they want to choose, but certainly encourage you, if you'd like to look at the full list of all 93 improvement activities, we certainly have that downloaded for you and can go ahead and send it to you in a handy dandy spreadsheet. So in the beneficiary engagement domain, activity 6 is a high weight activity. And so this says collect and follow up on the patient experience and satisfaction data on beneficiary engagement. So this is patient satisfaction scores. Again, this may be something that your practice is doing already. And if so, you can use that as your improvement activity, right? For those of you who are thinking about participating in the fourth quarter, this might be a great one to choose if you're already doing that. It's a high weight activity. You're halfway home on your 1 high weight activity out of 2 for the improvement activity category. All right. If you just want to avoid the negative adjustment and you want to do just 1, you're already there. Right. Here's another high weight activity in the expanded practice access category. This is providing 24/7 access to eligible clinicians or groups who have real-time access to the patient's medical record. Right. Again, many of you are probably already doing that. And if you are, that's 2 high weight activities. All right, let's look at another one in another domain for achieving health equity. This is really just having time available for appointments for Medicaid patients. So this is access to care for people in need in your community. You've got appointments available for Medicaid patients. That's another high weight activity. Activity 11, another high weight activity in the patient safety practice assessment domain, is participating in CAPS or other supplemental questionnaires. Right. So again, there may be some activities that your practice is already doing, or that your providers say, yes, this is something that we want to do. It makes sense. It's good for our patients. It fits with our specialty. This is the choice that we want to make from an improvement activity category. And again, you've got over 90 activities to choose from. Choose the one that makes the most sense, that has the most value for both your doctors and your patients. All right, so we've talked about advancing care information. We've talked about improvement activities, right? Those are the two smaller categories. The lion's share of what Medicare is trying to do are improve quality outcomes and reduce the cost of healthcare in our country. Those are the two biggies. That'll be 60% of your MIPS score. So let me talk about those two. I'm going to talk about cost first, because it's not going to be included as part of your final MIPS score in 2017 or 2018. That weight has been reallocated to the quality measures for those 2 years. Okay, but there's always a but. And the but here is that the cost category is going to be calculated. This is the only category that every MIPS eligible clinician will be calculated on in 2017 or 2018, because you're submitting this data to them already. Medicare is calculating this from claims data, and it's required by law to be 30% of the composite score by 2020. Right, so we think you'll start to see that in 2019. So they're going to calculate this based on claims data. So keep in mind, you are sending this information to Medicare every single day. Right, they are already paying attention to this. They are already calculating this. And even though it's not part of your MIPS score, that doesn't mean it's not important this year. Right, the way that I like to illustrate this, because I like pictures and they help me, is CMS is saying we want to start measuring and paying for quality and paying for cost effectiveness. And the pushback from the physician community has always been, you don't understand, that's not fair, because my patients are sicker than everybody else's. I see the most complex cases. And Medicare is saying, okay, prove it. Prove it. Let's look at the data. What does that look like? What does it say? And what is the data that they're looking at in order to calculate those types of cost measures? We know we're going to spend more on some patients than others. We know that's going to be highly impacted by how sick those patients are. So how does Medicare measure and adjust for patient acuity? This is where HCC coding comes into play. Okay? What HCC coding is, it means that sicker patients cost more and they have worse outcomes. Everybody understands that. But if we're going to do this sort of risk-based adjustment, if we're going to measure patient acuity, we have to have a mechanism to do that. And this is what HCC coding is. It's been used in the Medicare Advantage world since 2004, so this is not something new. It has been around for a long, long time, and it's a way to assign a patient acuity score to each individual patient. It has two main components: demographics plus diagnoses equals HCC score. On the demographic front, it's basically age, gender, and eligibility status. The older you are, the sicker you are, right? The sicker you are, the more you'll cost Medicare. If you're dually eligible for Medicare and Medicaid, right, you're going to have a higher HCC score. You've got a sicker patient. They're going to end up costing Medicare more. But it's not just demographics. It's also based on the diagnosis codes for the past 12 months. The diagnosis codes that this patient has had coded on a claim for this year are going into that HCC score. Okay? So that risk adjustment is going to impact some of the quality measures that are risk adjusted, and it's going to be heavily factored in to the cost measure under MIPS. Right? So, so a lot of people get frustrated by that when they look at that. They go, there's this gap between how sick I think my patients are, how sick I know my patients are. And Medicare doesn't understand how sick they are. They think they're actually pretty healthy. How do I explain that gap? Well, the difference is what we code, what we send to them in the claims data. And we've been operating under this fee-for-service world for a long, long time, right? In that fee-for-service world, it says, as long as I've got a diagnosis that makes it medically necessary, it doesn't matter. The claim's going to get paid. I don't need to worry about all of these comorbidities. And as we make this change from volume-based reimbursement to value-based reimbursement, capturing and coding and documenting those comorbidities is very, very important. Let's look at 3 identical patients that all need a total knee replacement. The first one only has the primary diagnosis, unspecified osteoarthritis of an unspecified knee, not to mention the fact that that claim's probably going to get denied because there's no such thing as a third knee. But that the second patient, we have a more specific primary diagnosis, but I also have a patient that's overweight. That patient looks sicker to Medicare. That patient has a higher HCC score. The gap between how sick I know my patient is and how sick Medicare thinks my patient is has gotten much, much smaller. In the third example, we also code type 2 diabetes with polyneuropathy. Now our pictures look the same. Medicare now knows how sick this patient is and has a proper expectation for what that patient's HCC score is and how much they expect to spend on that patient compared to the average Medicare patient. Right? So as Medicare starts to already calculate the cost measure, but as they start to score the cost measure, as they start to publish that data, that will become increasingly important. 2017, 2018, not part of your MIPS score, but still very, very important. From a MIPS scoring perspective, the largest category is going to be the quality measures. This is very similar to PQRS. If you want to fully participate, you need to choose 6 of the measures. Now, there are over 270 to choose from, so we've got lots of choices here. You look at the data, and the way that they organize it are, again, into these different 6 domains, and they've got process measures and outcome measures. All right? So let me show you just a couple of options so you can start to get a feel for this. Again, if you want the full file that has all of the 271 choices, happy to send that to you. Just let Shelley know in the questions panel. Patient safety domain, looking at an outcome measure. Are we documenting current medications in the medical record? Right? A lot of people participate in this particular measure under PQRS. Do we have a care plan documented? For patients over the age of 65, do we have an advanced care plan in place, or do they have a decision maker documented in the medical record? An outcomes measure in the ophthalmology world for cataracts patients. Let's look at the improvement in their visual function 90 days following cataract surgery. Right? Again, you've got a lot of choices here. Let's try to choose the measures that are most important, most applicable for your patients, for your specialty, for your providers. You're gonna do better from a scoring and from a process perspective if you can choose quality measures that match up with what your doctors actually do. Here's another one for orthopedics. This one's a process measure doing a function and pain assessment for our osteoarthritis patients. So we've got lots to choose from, but I would tell you the choices that you make on which quality measures you report are going to have the biggest impact in 2017 and 2018 on your performance, because quality is 60% of your score. Now, it's very similar to PQRS, but there are some differences that'll impact most of you who don't have a lot of experience with the value-based modifier. In PQRS, it was really paper reporting. As long as you report the information, you got credit for that and didn't have the negative penalty. But under the quality measures, they're really grading the tests, right? It's not just did you fill out the boxes. They want to know, did you get the right answers? It's 60% of your composite score, We talked about that already. Now there is a maximum of 6 measures that you can do. If you want to do 10 measures, and they will grade all 10 of them, but the top 6 will count towards your MIPS quality performance score. The tricky part about this is it's going to be graded against peer benchmarks. And there are different benchmarks for different measures, and there are different benchmarks for different reporting methodologies. I know that sounds confusing. Let me say it again. There are different benchmarks for different measures, and there are different benchmarks for the same measure for different reporting methodologies. Let me show you what I'm talking about. I'll give you a couple of examples real quick. One of the top PQRS measures that was reported in the most recent year we have data available, 2015, was the documentation of current medications in the medical record. And you can see these different color bands represent the different deciles of performance. So if you scored in the blue, right, you would get 3 out of 10 possible points for that quality measure. If you scored in the red, you would get 4. If you scored in the green, you'd get 5, etc. And so you can see that if I want to report this measure via claims, I've got to score much, much higher to get the maximum number of MIPS points than I do if I report via EHR or if I report via registry. The other thing to note is this measure is topped out. What that means is there's not a lot of difference between the average performer and the top performer. And so CMS is going to look to sunset this measure going forward, right? It used to be low-hanging fruit, but not for long. And you need to factor that into your decision of which quality measures you want to report on. Just a couple more real quickly. You can see a bit more variety in the performance as you get to different types of measures. And they're not all the same. You notice the last one, it was easiest to score best by using registry reporting. This one is easier to score best using the EHR reporting. So something that you need to consider in addition to just what measure you think might be the easiest or which one makes the most sense for your clinician is what the benchmarks for those measures are, okay? So something to think about. If you've got questions on that or want some access to that data, we can certainly point you in the right direction there. And I know we've jumped into the nitty-gritty, but what I want to remind you of is we've got the 4 categories. Quality is going to be the largest for the first 2 years. Cost and quality is what they're going to care about the most long term, okay? And that can all sound overwhelming, but let's put that back into perspective of what needs to happen for 2017. Some of you are reporting for a full year. Some of you are going to do that for a partial year in the 4th quarter. But you're really able to do that without a large financial penalty. Very easy to submit something to get over that score of 3 points for this year. And the jump to 15 will be an increase for sure, but is very doable for 2018, okay? So what I want to look at is I'm going to walk through some of the scoring methodologies because I think that's important to understand because a lot of the data that's available on the CMS website makes it look like it's a pretty easy to calculate score. If you're below the performance threshold, you're going to get a negative adjustment. The maximum negative adjustment is -4%. That part is pretty straightforward, but when we look at the positive adjustment, everybody assumes, oh, you can get a 4% positive adjustment. And that's true, but it is not the complete truth, right? When you look at it, another graph that people may be familiar with when you look at this is as we make the transition to MIPS, as I get, the higher my score, the higher my positive adjustment is, and if I get above the exceptional performance threshold, I'll be able to participate in those bonus dollars. And yes, that's true, but what most of these graphs leave out is that the MIPS adjustments are required to be revenue neutral by law. Okay, and let me show you this because I think this is the easiest way to understand this. my score is going to be compared to my peers, and if I'm over the performance threshold, I get a positive adjustment. If I'm under it, I get a negative adjustment. Yes, that is true, and that adjustment will be made to my fee-for-service reimbursement in 2019. However, and what's required is that the negative adjustments, the total negative adjustments, have to equal the total positive adjustment. What that means is, if you're getting a positive adjustment, those dollars are not coming from the government, they're coming from somebody else's pocket. So they're going to take all of the negative adjustment dollars, and that's what's available to distribute as a positive adjustment. Right? So if there aren't a lot of negative adjustment dollars, there won't be a lot of positive adjustment dollars either. Let me see if I can explain it with an example, because sometimes that helps make things a little bit easier. Let's assume, for sake of simplicity, that there are only 2 practices in the entire country. My practice and Practice A. Now, my practice, we've done a great job. We participated well. We even got the exceptional performance score right at 70. But Practice A, they didn't do so well. They didn't participate at all. And they got the 4% negative adjustment. Now, since there are only 2 practices in the world, that means we're eligible for a 4% positive adjustment, which is great. Yay, right? Now, let's assume that there are 2 practices now. My practice and Practice A and Practice B. Practice B also gets a MIPS score of 0 and a 4% negative adjustment. Well, I did nothing differently, but you know what happened? There are more dollars available for me. I don't get a 4% positive adjustment. I get an 8% positive adjustment. And that really makes me happy. That's a good day for me. But what happens through no change that I made? Practice B actually did a good job. Practice B got the same score as me. And you know what that means? My positive adjustment just went down. Because Practice B and I now have to share. And there's not as much for us to share because there's only one practice out there that got the negative adjustment. So I'm not doing this in a vacuum. How other people perform impacts not only my score, but what dollars are available for my practice. Okay, and so what that means is, let's add some dollar amounts to it, because it's not, you don't get paid in percentages, right? So let's assume that when I look at these practices, Practice A only has 3 providers. It's a small practice. They bill Medicare a total of $100,000 for all 3 providers. So the total negative adjustment for Practice A is only $4,000. Right? 4% times 100,000 is $4,000. Now so that means it's about $1,300 per provider in that group. Now my practice is a bit larger. We're 30 doctors, bill Medicare for $1 million a year. But my total positive adjustment is only $4,000. You see, because Medicare only has $4,000 to give me, because they only took $4,000 from Practice A. And so that means each provider in my group only got $133, which is not a 4% positive adjustment. That's a 0.4% positive adjustment. So when you look at information from Medicare that looks like this, you've got to pay attention to that asterisk. Because that asterisk means there's another number that goes in there. We don't know what it is yet until we know how many people were unsuccessful with MIPS in 2017. Right? So what that means, what it's going to look like at the end of the day, is there will be some people who get the less than 3 score. Many people will fit in the middle, who will receive what Medicare is calling a small positive adjustment. Based on the numbers that we've run, we expect that to be about $350 per provider. Now, those of you who are really going for the gold and may be able to get over the exceptional performance threshold, your positive adjustment will still be relatively small, but the majority of those dollars are coming from the exceptional performance bonus. Okay? So I say that to kind of put that in your head. So it says, okay, as we think about this, our financial consideration may not be that large, right? It may not be that we do this strictly from a financial perspective. And one of the things that I want everybody to be aware of is Medicare is interested and has said that they will publish this data on the Physicians Compare website. This may be the most compelling reason to think strategically about MIPS for your practice. We're going to publish this on the Physicians Compare website. Let me show you what that looks like today. I've taken the identifying information out of this and just said we've got, I went online and looked for orthopedic surgeons in Birmingham this morning and compared 3. Now you'll notice as a patient, this is not particularly helpful information. I've got their name, their address, and do they accept Medicare or not, and is their performance data available, right? So what they give you on the first screen, not particularly helpful, kind of what you'd expect from a government website, right? But if you want to drill down and look more specifically, let's look at Stephen. If I drill down and look at Stephen, I can actually see the performance scores available for that individual provider. Everything on this screen came from the Physicians Compare website this morning, except I changed the name. Everything else is real. So you can see the PQRS measures that he's participated in. Let me go to the next provider and show you what I found. Right? Now, we know, because we're involved in this industry, what it means for an orthopedic surgeon to be screening for high blood pressure, developing a follow-up plan. That's not what they do. But they participated in that PQRS measure, they reported on that data, and now CMS is summarizing this information on their website with a star rating that everybody's familiar with because they look at it when they book an Uber driver, they look at it on Amazon, and you run away from people that have a 1.5 star, right? You may not even read what the label is. This is some of the information that our patients are going to be seeing. This is data that's available right now. And what I want to ask you to think about is, what would it look like if, rather than showing information like this, Medicare took the same data and formatted it like this, to where you saw those PQRS measures, Medicare is calling these quality scores, on the front page. What does that do when patients see that information? Medicare has published APIs where Yelp and other people can pull that data and format it in whatever way, shape, or form they deem appropriate, right? And then what happens, let's say, for example, that once they start collecting this MIPS information and calculating these MIPS scores, again, this is a mock-up, this is not something that's available today, but what would happen if they start showing the MIPS scores and the individual category scores on the Physicians Compare website? We know that they're going to collect that data. We know that they're going to publish that data on the Physicians Compare website. We don't know where they'll put it or what it will look like, but this certainly has an impact on your doctors and on your patients. So I don't want to spend a ton of time on that because it's projecting out into the future, but I do want to make everybody aware about that so that you think about that as you think about your MIPS strategy. All right? We've covered a lot of ground. I'm going to launch our last poll question. I've got one more slide, and then we're going to answer any questions that are broadly applicable for the group. But the poll question is this: think about your practice, think about your doctors, and which MIPS category do you think will be the most difficult for your practice? Which category is going to be the most difficult for your practice? Quality, cost, advancing care information, right? That's the new meaningful use, and then improvement activities, right? Both right now seems to be split between cost and advancing care information as kind of our top vote getters. Quality is making a late surge, as some of you are still voting. Just to give you an idea, right now it's advancing care information number 1, cost number 2, quality number 3, and improvement activities number 4, as voted by your peers. So thanks for participating in our polls. I always think those are fun. I hope that is helpful information for you as well. Zoom way out. Let's think about our takeaways from today. What do I want you to remember from today? There is still time to avoid the negative adjustment in 2017. Do not despair. If you have not started, you still have time to do that, and your practice should be able to do that successfully. If you need help, if you have questions, please feel free to reach out. We would love to help you with that in any way that we can. Number 2, there are some small changes in 2018. Probably most notably is the performance threshold is moving from 3 to 15. Again, just my opinion. You may see that come a little bit down as the last minute lobbying shakes out. You may see that come down just a little bit. But it's not going to be a quantum leap forward from 2017 to 2018. There's still going to be a relatively low bar. And that's something that you can certainly be successful in. Small practices will get the bonus points. Even for people who do not have an EHR, they can be successful with MIPS in 2018 as well. Number 3, make sure you think strategically about your choices. Think strategically about, do you want to report as a group or as an individual? Think strategically about which quality measures you want to pursue, what the benchmarks are, where you can be successful, what will have the biggest impact for your patients and your doctors without adding unnecessary administrative burden to them. And think about what Medicare is doing with the data that you submit. Think about what they're doing with the claims data when you do or do not code comorbidities. Think about what they're doing with the MIPS score data on the Physicians Compare website. Because if we don't think strategically about this, it's like steering a big ship. It takes a long time to make a difference. They publish this data on the Physicians Compare website, and you've got doctors that are upset about that. Right? In order to make that change, it's going to take at least 12 months for your next MIPS score to be out and then to be published. It's not something you can change quickly. Okay? We covered a lot of ground. Thank you. Thank you for your time. Thank you for being here. Thank you for participation. Do remember, we've got the short 3-question survey at the end. When you close out, you'll get that pop up. So please, 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 if this has been helpful for you, take a minute to fill out that survey. If this has been terrible, take a minute and fill out that survey, because I would love to hear that feedback as well. I'm going to turn it over to Shelley and see what